Tulsa Life Flight can be requested by any first response agency such as police departments, fire departments, EMS, industrial response teams, and also private citizens that may have pre-registered with Tulsa Life Flight. There are some general guidelines when determining whether a patient needs air medical transport.
Air transport may be necessary when the patient has multi-system trauma or penetrating trauma with unstable vital signs, such as a systolic blood pressure of less than 90 millimeters, respiratory compromise with a rate of less than 10 or greater than 29, or a Glasgow coma score of less than 14. Some time-dependent injuries and illnesses can also require air transport. These are penetrating injury to the neck, head, torso, or groin, a combination of burns greater than 20% or involving the face, hands, feet, or genitalia, amputation above the wrist or ankle, paralysis, flail chest, 2 or more proximal long bone fractures, open or suspected depressed skull fracture, unstable or suspected pelvic fracture, near drowning, abdominal or thoracic aneurysm, acute intracranial bleeding, status asthmaticus, croup epiglottitis, cardiogenic shock, post-cardiac arrest, and acute myocardial infarction.
Coordinates are north 35.56.5. That's north.
Communication plays a vital role in air medical transport. When you call Tulsa Life Flight, the air communication specialist will need to know the agency requesting response, a callback phone number, the location of the scene, the number of patients and their condition, the radio frequency, and the designated ground contact.
This information is critical in the safe response of the air medical helicopter and is used to alert the receiving hospital. The incident commander should assign someone to stay in radio contact with the helicopter at all times. Our goal is rapid response, but this time could be extended if communication problems occur. The person in contact should advise the helicopter crew of any hazards or obstructions at the scene. Also, the exact location of the landing zone and any patient information is very helpful. Always speak clearly so that any misunderstandings are avoided.
During daylight operations, we would like you to choose an area for us to land that's at least 60 by 60 feet. At night, the landing area should be at least 100 by 100 feet. The landing area should be free of overhead obstructions such as wires, trees, towers, and street signs. Also, clear away any loose debris that may be lying on the ground.
The surface area should be relatively flat with a slope of no more than 10 degrees. If the landing area is dry and dusty, we may ask the responding fire department to wet the area to prevent loss of visibility on landing because of blowing dirt or sand. During daylight landings, signals such as smoke, signal mirrors, and orange panel markers can be helpful to guide the pilot, along with good radio communications. Flares are not a good landing area marker because of the fire danger. If you hear us approaching your location, it can be very helpful if you can tell us if you're located north, south, east, or west of our position. For a night landing, use vehicle light bars, strobes, flashlights, or headlights, along with radio communications. Scenes are easily located during night operations because of the vehicle lighting, but obstacles and obstructions are not easily seen from the air. Parking vehicles under wires is helpful in locating those hazards at night. Giving us landmarks to look for, such as water towers or other objects that are easily seen from the air, can be very helpful. We'll need to know the distance and direction from the landmark. A few minutes before landing, we will call asking for a description of the landing area, including any obstructions. The medical crew would also appreciate a brief patient report if possible. As the aircraft arrives, we will circle the scene at least one time to confirm the location of obstacles and to confirm the ground condition. The pilot may elect to find another landing area after his high reconnaissance. He may see something from the air that can't be seen from the ground. Once the pilot is satisfied that the area is safe, he will begin the approach into the landing area. During night operations, when the aircraft is approximately 150 feet above the ground, we ask that vehicle headlights be turned off to prevent blinding the pilot. If you see that the aircraft is getting close to an obstacle or obstruction, a command of stop over the radio or a wave of the arms in the air is appropriate. The pilot will then abort the landing. Patients who are not in an ambulance should be covered and protected from the aircraft rotor downwash. Protect yourself by turning away from the aircraft and by wearing eye and hearing protection. The winds generated by the rotor system of our aircraft can be as high as 80 to 90 miles per hour. After the aircraft has landed, the crew will exit, and the aircraft will continue to operate until it's determined the aircraft should be shut down due to a prolonged extrication, close proximity of personnel, or other determining factors.
Safety around helicopters is essential and can be life-saving. The rules are common sense in nature and should always be observed while working with the helicopter. The general rules include no smoking within 50 feet of the aircraft, keep your face covered during takeoff and landing, protect your patient with a tarp or blanket during landing, keep bystanders at a distance of at least 100 feet from the aircraft, always approach the aircraft from the front in full view of the pilot. Never approach the helicopter from the rear. Always alert the flight crew of potential hazards on scene. Secure all loose items on scene and your person. While working around the helicopter, keep all equipment below shoulder level. No running on scene. Stay calm and professional. Always wear hearing protection.
Please do not approach the aircraft if the rotors are turning unless directed by the pilot or the medical crew. If you're directed to approach the aircraft, make eye contact with the pilot and he will motion for you. Do not approach from the rear of the aircraft. Always approach from the front or the side of the aircraft. The medical crew will give instructions for loading. Our aircraft loads from the rear. If we have elected to keep the aircraft's engines operating, this is called hot loading. During a hot load, the pilot will move to the rear of the aircraft to supervise the load. All equipment must be secure prior to approaching the aircraft. A minimum number of persons will come to the aircraft to assist in the loading operation. Do not go past the pilot toward the tail rotor for any reason. The pilot can be easily identified because he will have a flight helmet on. Some important things to remember when a hot load is required. Stay back if you're not assisting with the load. Follow directions provided by the medical crew. Remember, the ability to communicate will be decreased drastically because of engine and rotor noise. There will be heat from the engines in the loading area. You should move slowly and purposefully. After the patient has been loaded, the pilot or medical crew will direct ground personnel away from the aircraft. In the event of an aircraft accident at the scene, please stay clear of the aircraft until all motion of the rotor blades is complete. The aircraft uses JP4 Jet A fuel. If a fire occurs, it will be a Class B fire. Helicopter windows are made of plexiglass. The door jettisons are labeled with bright orange tape. Open the door to the jettison and pull the handle while simultaneously pulling on the door handle. Do not cut through the bottom of the aircraft to extricate crew because the fuel tanks are located there.
Thank you for watching this informational presentation. We value your assistance and look forward to working with you when you need us. Working together as a team, we will provide patients the best in emergency medical care and the fastest transport available.